we're delighted to have Dr. Nancy O'Hara back with us. She was kind enough to do a webinar with us all on the 1st of February. And she's now going to give a presentation and do lots of Q&A at the end. So do please put your questions in the chat and the Q&A. Apologies, I've just come back from Germany and I have a little bit of a cough still. So Dr. O'Hara will introduce herself today, and after 45 minutes or maybe a bit longer of presentation, we'll have lots of time for Q&A. Thank you so much, Dr. O'Hara.
Great, thank you, Gillian, and welcome to everyone, and thank you for inviting me back. I will share my screen now, and we'll go ahead and get started. You know,
Dr. O'Hara, sorry, would you like to just say a few words about yourself?
I will.
For
Absolutely.
Those who are joining.
I absolutely will. I do it at the second slide, so no problem. We're going to talk today mainly about case studies. And, you know, this is a slide my mentor, Dr. Sidney Baker, always used. Follow those who seek the truth, but flee from those who have found it. And that really applies to PANS and PANDAS because many of us in allopathic medicine don't even believe in it, let alone know how to treat it. And, you know, I am an allopathic pediatrician. I started my career as a teacher of children with autism, and I was a really lousy teacher. So I took the easier road and went to medical school. And after residency, chief residency, and general pediatric fellowship, I found myself as a partner in a general practice with a lot of children with autism, but also with my own battle with infertility. And I actually had a child get better from autism with diet. And the mom came to me and she said, "You've got to look into this." Now, back then, this is 30 years ago, I thought that was hooey. But because I was going through infertility, I went to Dr. Sidney Baker, who is the grandfather of functional medicine, as a patient, and that changed my life. When my neurotypical son was then 9 years old, he devolved into seizure-like tics after getting a strep infection, getting bit by a Lyme-positive tick, and getting a live virus vaccine all in the same week. And that's how I entrenched myself in PANS and PANDAS. And since then, in the last 16 years, this has been the focus of my practice. I wrote a book about it. That was my COVID baby, much more difficult than my own baby. But that's what we're going to talk about today. We're going to go over some cases and then recap at the end. This is from the 2012 white paper. You know, Sydenham's chorea is the prototype of PANS and PANDAS. That's the big choreic involuntary movements that come after rheumatic fever from strep. In the 1990s, Sue Sweeto coined the phrase PANDAS, pediatric autoimmune neuropsychiatric disorders associated with strep, for those children who had abrupt onset of neurobehavioral symptoms after a strep infection. There were also other infectious triggers like Lyme, mycoplasma, viruses. But in 2012, they tried to make it less controversial by expanding the definition to include other non-infectious triggers like pesticides, mold, chemicals, metabolic disorders, etc., and coined the phrase PANS, pediatric abrupt onset neuropsychiatric syndromes. Didn't make it any less controversial, actually made it more controversial. But that's really what we see. And it's the interplay of the genes with the environment. So you have to have a genetic susceptibility and then environmental triggers like an infection or others, and then how that affects the gut and particularly the immune system. And when there's the immune system reacting against self, then you end up with PANS or PANDAS. The causes are strep, as I said, mycoplasma, all different types of viruses. And we've definitely seen it post-COVID. And if there's any silver lining of COVID is that it helped more physicians to see infections as triggers for behavioral changes. But yeast and mold can also cause it. All forms of tick-borne diseases, particularly Borrelia, Bartonella, Babesia, and yes, it is in England and anywhere else you are in the world. Metabolic things, as I mentioned. So you're always looking at the history. That's the biggest biomarker for this. Not any lab tests, but the history of a preceding trigger, infection, prodromal illness, and then the changes in behavior. So these are just some statistics. You know, more than 40%, almost 50% of children in the United States, because we're the sickest country in the world, in my opinion, but more than 40% of kids have a chronic illness. 1 in 200 children have PANS or PANDAS. About 25% of children after COVID have some other either long COVID or more commonly a neuropsychiatric change. And then over 500,000 people, but probably many, many more than that, have Lyme disease. 42% of the children in our practice have Bartonella, and more than 40% in our area, which is the northeast part of the US, carry Babesia. But it is everywhere, as I said. So the diagnostic criteria is an abrupt or dramatic onset or recurrence of OCD. Now, it can be subacute, especially if it's mold, yeast, or any of the Lyme tick-borne disease triggers. Or if the abrupt onset occurred very early in life and it wasn't even recognized. They got a strep infection, their behavior really changed, but they got better after using an antibiotic. Now, 4 or 5 years later, it's more subacute, but it still could be PANS or PANDAS. 20% of kids will present with a restrictive eating disorder. And then in addition to one of those, they also have to have 2 of these. New onset of separation anxiety, emotional lability, developmental regression, handwriting deterioration, tics or other motor abnormalities, processing problems, brain fog, even abrupt onset of ADD. And then especially if they have one of those together with a somatic symptom, like urinary symptoms that came out of the blue, or a sleep disturbance like REM disinhibition. They become very restless sleepers. That is the diagnostic criteria for this disease. And I learn in pictures, so I wanted to give it to you this way with the percentages. 90% of these kids have some type of urinary symptoms. 80% have a sleep disorder. As I said, 20% have that restrictive eating due to fears of contamination or choking or vomiting. 80% will have that deer in the headlights, hyper alert appearance. 90% will have a handwriting deterioration. So if you have any of these symptoms and their handwriting abruptly change, that's this disease. And the kids that get admitted to psychiatric hospitals are often the ones with hallucinations. And those are the ones we really have to treat with IVIG or plasmapheresis, et cetera. The rest we can really treat in other ways. And that's what I'm going to show you in the cases. So just think about it this way. For strep, for instance, you get exposed to strep, you have strep throat, and in those who are genetically susceptible, they have a misdirected immune response, what's called molecular mimicry, where the antibodies or the proteins, rather than attacking the strep in the throat, instead cross the blood-brain barrier and attack the basal ganglia, that area of the brain that's responsible for OCD, anxiety, and tics. And they get basal ganglia encephalitis or inflammation and get these symptoms. More and more kids are getting this because we live in a toxic world and we're having more and more breakdown of our blood-brain barrier, sort of like what we've heard about with leaky gut. We now have leaky blood-brain barriers. And this is an excellent video all on that, that I encourage you to watch if you have not. So when we find it, the treatment always have to be a 3-pronged approach. Treating the symptoms, removing the source, so treating with appropriate antimicrobials. And I just saw a child this morning who had seen another doctor, and the trigger in that child's case was COVID. And the doctor put the child on antibiotics and the child didn't get better. Well, they're not going to get better because the trigger wasn't strep. It wasn't a bacteria. It was a virus. So we have to treat them with antivirals. So treating the symptoms, treating with the antimicrobials, and especially treating with the anti-inflammatories. modulating the immune system. So let's see how I did this in individual kids. James was a child that I first saw at age 9. He had a huge family history of autoimmune disease. And as you saw from one of those slides, 64% of these children have first-degree relatives with autoimmune disease. And this child had a lot. Mom had thyroiditis, lots of allergies, asthma, and even rheumatic fever in dad and several grandparents. The child was healthy. He was a sensitive kid, and that's something I often see in these genetically predisposed kids. They have sensory processing or auditory processing issues before they have the abrupt changes. But he definitely had constipation. And then everything changed on August 25th. And that means this is PANS or PANDAS. We rule out the other things, but that's what this is. So they were on vacation, and overnight, he developed extreme anxiety, emotional lability, afraid of the dark, constantly asking to be carried by mom, extreme sensitivities to clothes, ritualistic behaviors, only drank out of a certain cup, walking in certain behaviors, becoming a very picky eater. And then 3 days later, he developed these choreiform movements. So remember with Sydenham's chorea, I said there are these big choreic movements. Choreiform movements are more subtle movements. And he was doing a head rocking movement over and over and over again. And so the mom took him to a local walk-in clinic while they were on vacation. And thankfully, the doctor there knew about PANDAS and suspected it. The child was so off the wall, he was trying to climb out the window, so they couldn't even get a throat culture. But the doctor put him on Augmentin, and he improved. Now, he came to our office 6 weeks later. He still had constipation. He still was a very picky eater, very bland diet. His handwriting was still abysmal, and he still had irritability and anxiety. So we wanted to get to the bottom of it. And on exam, he had choreiform movements. And as parents or practitioners, you can do this at home. So you have the child stand with their feet together, and they stretch their arms out with their elbows locked and their fingers stretched out, and then shut their eyes. They should be able to stand there with their fingers stretched, holding them steady for 30 to 60 seconds. If they start playing the piano with their fingers or supinating, rolling their hands, that again is pathognomonic for PANS PANDAS, for basal ganglia encephalitis. He also had white spots on his nails. Many of you may know what that is. That's usually zinc deficiency and an otherwise totally normal exam. We did lots of testing, and I'll go over that. We test the strep antibodies. We test for mycoplasma. We always test even through a conventional lab for Lyme, but often we need to do a specialty lab, and I'll show you that in another case. Iron, thyroid function, and all the immune markers. The ANA is the most commonly positive. That's an anti-nuclear antibody. Any conventional lab can do it. And that's positive in about 60% of kids. We also check immunoglobulins to see if they have any signs of immunodeficiency, and strep pneumococcal serotypes. Most children have been exposed to either the Prevnar vaccine or pneumococcus as a disease, so they should have built up immunity to this. This is not group A strep that you get in the throat. This is a pneumococcal infection. If they haven't built up immunity to it by the time they're 5 or 6 or 7 or older, then that's a sign of subtle immunodeficiency. We also check minerals in the red blood cell like zinc and magnesium, antioxidants like vitamin A, vitamin D, and even through a conventional lab, you can do urine organic acids, looking to see if there's any abnormal metabolites that may show you yeast overgrowth or mitochondrial dysfunction or dysfunction in fatty acid oxidation or glutathione production. So those are our usual tests that we do, and that's in my book. As well as I'm glad to share these slides with Claire and Jillian so that you can have them. These are the test results for him. The ANA was positive. As I said, it's a very low positive, and the rest of the panel is negative, meaning he doesn't have lupus or MS or any other collagen vascular diseases. His vitamin D, as I always say, is in the toilet. 85% of children in our practice are vitamin D deficient. And vitamin D is very important for decreasing autoimmune disease, improving mood, as well as several other factors. His zinc is also low. This was just a plasma zinc. They weren't able to do an RBC zinc. So when the plasma zinc is low or low normal, as this one, the very low end of normal, we want to treat that. But his strep titers were normal. So this isn't PANDAS? No. The strep titers are not a marker of PANDAS. They can be totally normal and it still be PANDAS. They can be elevated and it not be PANDAS. And then also the RBC magnesium was very low, which we would anticipate in a child with constipation and these types of behaviors. Magnesium is very important for over 300 enzymatic functions. Without it, you get hyperactivity, anxiety, twitches and tics, insomnia, constipation, even salt craving and sighing behaviors. If a child is constipated, we will either use citrate or oxide. If they can't take anything, even Epsom salts or magnesium chloride baths. If they have brain fog or poor sleep or tics, we will often use magnesium glycinate or magnesium threonate. And I'll go over that more later. Zinc is also very important, especially if they have acne, sores on the sides of their mouth, they're eating non-food substances, they've lost their taste and smell. Those people that did that during COVID, almost all of them were zinc deficient. And then, of course, the white lines and spots on the nails like you see here. This is a test that a lot of people do. This is Molecular Labs, a very accurate test. It was first developed by Madeline Cunningham, so it's also called the Cunningham panel for Sydenham's chorea. And as you can see, it's very elevated with Sydenham's chorea and also elevated with PANDAS, but not in children that don't have PANDAS. So if you have OCD, tics, or ADHD that is not due to a strep-induced PANDAS, the levels will be much lower. Now, there is some overlap between this 100 to 150, but anything over 140, 150, again, is pathognomonic for PANDAS. Now, you can have a normal CAM kinase and still have PANS due to mycoplasma or Lyme or mold. So this test is very expensive, and I really only use it when the case is atypical and I'm not getting results. And it's more accurate when the child is in a flare. So what did we do in this child? I don't want to continue augmentin because it's very hard on the gut. So I started azithromycin and weaned it down to prophylactic dosing. So if you're doing azithromycin once a day, you can wean it down to once per week. So I usually do that over the course of 6 weeks, decreasing by 1 pill per week till we're down to 1 per day. And if as I decrease it, there's any worsening, I will increase it back up. That's if I have the ability to prescribe antibiotics. Otherwise, I have a lot of great herbs, and I'll talk to you about those. The probiotic, especially when they're on antibiotics, is very important to prevent yeast overgrowth or other infections. He definitely needed vitamin D, and best is vitamin D3, K2. And we gave him about 2,000 IUs. Zinc picolinate, one of my favorite forms, at about 30 milligrams, and magnesium to bowel tolerance. We wanted to get him off that Miralax. So we increased up to 1,000 milligrams of magnesium, slowly titrating up to get him to have formed but soft stools. Mom even made gummies out of the magnesium, and I put her recipe there because it was a very healthy way to get it in. CoQ10 as an anti-inflammatory and also to help him with some of the brain fog he was having, more essential fatty acids because he wasn't getting enough in his diet. That also helps the stooling. And then I really like curcumin, and I'll show you several forms of that as an anti-inflammatory. As a former teacher, I'm a big believer in therapy, and CBT, cognitive behavioral therapy, or DBT, mindfulness training, meditation, are all really important for these kids. And starting about 6 weeks later, he was doing great. No tics, more social, more cooperative, and really doing well. But as with most of our kids, even after they get better, they can flare again. He was maintained on an antimicrobial rotation of herbs, and I'll show you some of those in one of the other cases. But then he had a big flare with irritability, OCD, and rigidity. So we were looking for what caused this. And what it was at that time was he had lost a bunch of teeth and had 2 new eye teeth coming through. Teething, because it impacts and inflames the cranial nerves, can cause more inflammation in the basal ganglia. So in those cases, ibuprofen is about all you can do besides treating the symptoms until that is passed. Sometimes kids that improved with belladonna or something else for teething may improve with that, but mainly just ibuprofen. He also had a flare when his sister had strep throat and when there were viral illnesses in the family. So we have an acute viral protocol that we do, which is just antioxidants, increased doses of vitamin A, vitamin D, zinc, and lysine, which is a great antiviral amino acid. And we will sometimes try to prevent strep, put siblings, if they're getting repeated strep infections, on herbs to try to prevent them from triggering the child. So we added ibuprofen in this child, as I said. We added an antihistamine as another anti-inflammatory. And in this child and in other children, we have added what's called Hellman therapy, which are grain beetle worm eggs. This is a very safe intervention for children who are not constipated. And I highly recommend you looking at Biome Restoration. It's a company out of England. And I also have a lot of information on that. That's a whole nother talk. But I have a lot of information on my website under the blog section on Hellman therapy for you to learn more. After doing these interventions, his handwriting went from that to this. So we really saw a big difference in a very short period of time. And in his own words, prior to treatment, he had to have imaginary friends to feel safe. He was tired. Everything tasted like starched shirts that he ate. He felt like he had to go to the bathroom all the time. He felt clumsy, stupid, afraid, angry, crawling out of his skin. And then afterwards, he still had some anxiety, but he was able to manage it and work through it. He didn't need to write things over and over again. He was able to play and be calm without feeling like he was going to fail or fall, and felt much more like himself. Okay, another kid. This one's Charlie. He first presented at age 14. Now, his medical history was one of abrupt onset of anxiety, OCD, anger, and aggression, and a more subacute onset of migratory joint pain. And it all started in August of 2023. He had been bit by a tick in June of 2023 and had been put on doxycycline for 3 weeks. But the tick was not sent for testing, and he had a very challenging time tolerating the doxycycline due to diarrhea and nausea. So he probably didn't get a full dose. He began working with a therapist and a psychiatrist and was put on multiple psychiatric medications that he didn't tolerate. So he came to see us, and this was his back. These are the blanching striae that we see. This is horizontal. They can be horizontal or vertical. They don't follow dermal lines, which are usually in a slanted pattern. And they blanch. When you press on them, they turn color. They were told by the pediatrician that it was due to a growth spurt, but growth spurts, stretch marks do not blanch, and they follow dermal lines in that slanted pattern. These are not growth stretch marks. And this is showing, this particular study looked at that indeed a lot of these children will have Bartonella lesions, these stretch marks, and neuropsychiatric symptoms, and we really should be looking for Bartonella. Bartonella is transmitted from the saliva and scratches of cats, but it's also from fleas, from lice, from dust mites, from flea feces. Sometimes dogs, blood transmission, mother-child transmission. It's not just from ticks. So there's lots of ways to get Bartonella. The symptoms can include muscle and joint pains, headaches, brain fog and fatigue. Slow processing speed especially is very common. Tics, twitches, and migratory sort of feeling like antsy. And also neuropathy, which means that they're feeling pain or weird sensations or decreased sensations in their hands or their feet. They can also present just with eye findings. And the most common in kids is that daily flare. Many children with PANS and PANDAS have an episodic presentation. It comes and goes. But with Bartonella, it's always there, and especially rage and aggression. They can also have anxiety, depression, OCD, foot and heel pain, and those stria that don't follow dermal lines and blanch. And this is the back. This is actually my own son. Don't tell him I showed the picture. That first picture was also my son. He doesn't let me show any pictures now that he's 25, but I throw some in of him as a much littler boy. But anyway, so how do we prove Bartonella? It's the clinical diagnosis of abrupt or subacute onset. They can have those choreiform movements, the piano playing fingers, and evidence of inflammation, like that ANA. They may also have a low CD57. The culture is not accurate. So anybody says that the culture is negative, it can't be Bartonella, that's not true. These infections particularly go dormant. So you can often not find them on testing. They're either surrounded by biofilm, which is a mucus layer, or they're deep within tissue or red blood cells. The CDC does say that no testing is accurate, but their answer is to not test. But their answer is also to not treat, because no studies, in their opinion, shows that Bartonella can be spread to humans from ticks. It can be, and it can be spread from all those other things that I showed, the cats, the lice, all of that. So if you have, or your child has those symptoms, they should be treated. The tests from a conventional lab are not accurate. My favorite tests in this country are Galaxy, and particularly the PCR or the serology, and IGeneX. The Immunoblot has 100% specificity and greater than 93% sensitivity, whereas the typical conventional test we do only has 57% sensitivity. So that means that there are 43% false negatives with conventional testing. That's a lot. So if you're going to test, you really want to do those. MDL, Armin Labs, Red Labs in Europe does a great job with Borrelia, not quite as accurate with Bartonella. But you want to make sure whatever lab you use has validation studies. But this is very hard and very expensive for most of us to do. So I also often go straight to treatment. Now, there are a lot of different antibiotics that people use, and you need to use at least 2 of these. So azithromycin and Bactrim, clarithromycin and rifampin, doxycycline, and one of the other ones, methylene blue, and clotrimazole or other azole antifungals, which can be helpful. But that's a lot for a young child. So I really like to use herbals because Bartonella is very hard to treat and takes a minimum of 3 months to treat. So I've listed many of them as well as dosages here. I want to mention that even in the antibiotic treatments, they do often use herbals like oil of oregano, which is a great antifungal, anti-strep herb, and grapefruit seed extract, which is a biofilm persister cell buster. So that can be very helpful. There are other combinations, and I'm not going to go through the details of the antibiotics because most of us cannot get those, but I want to talk to you more about all of the different herbs. So I do have a website where I sell herbs, and I believe I've given Claire and Jillian the link and the password. It's only available to people that I mentor or who are members, but I gave Jillian Claire, I believe. If I did not, I will do that after this lecture. But these are all herbs that have been very well tested. The ones that I like to use for Bartonella are Hatunia, Campsiandra, and Stevia. With this, I get over 90% success within 9 months. And that's better than I get with any antibiotic regimen with a lot less problems. The others that people like are Japanese knotweed and Cryptolepis, also very good, as well as Artemisia. And I listed a bunch of the studies. You know, this is all very well studied. And these are all interventions that can work for our kids. So when I add Hatunia, Campsiandra, and then I add Stevia, I get 90% success. So 50% with only Hatunia alone, 75% when I add Campsiandra, and then 90% when I add Stevia. I start with 1 drop of each, increase by 1 drop per day, and in adult-sized kids, up to 30 drops twice a day. But I calculate it via Clark's rule for the weight in children. So let's say you have a 75-pound child, which would be about a 30-kilo child. That would be 15 drops twice a day. So that's how I judge the dosage, by Clark's rule. If that doesn't work, I'll pull out the Campsiandra and add Cryptolepis. There's a wonderful company called Limecore. It's limecore.com, where you can get a very good form of that. Or I'll pull out Stevia and put in oil of oregano. If there's no improvement, or if they relapse, then I'll add an enzyme to help break up the Bartonella nests. And lumbrokinase is my favorite in that dosage. And I give that about 15 to 20 minutes before the herbs. I also use immune modulators, and these are 3 of my favorites. Probiotics and prebiotics, certainly. Aloe, in this form, aloe is very safe. You don't want to use a latex form of aloe for too long. You can use it initially, especially for constipation, because it's a nice laxative. But aloe in the gel form, or in this capsule, which you can open up, has very good antioxidant and anti-inflammatory properties. This form of turmeric is my favorite form of curcumin. It has wonderful anti-anxiety and anti-inflammatory properties. I will even give up to 10 drops an hour to decrease the symptoms if the child is in a flare, and that works in at least 60% of the kids. We also started using a lot of specialized pro-resolving mediators during COVID as a great anti-inflammatory and immune modulator to help kids withstand immune and other challenges. This is a gel cap, so if kids can't swallow pills, it's kind of difficult. This is a liquid, and this is a capsule you can open up. So this is Charlie with that regimen. At 3 months, there was already a noticeable improvement, decreased joint pains, real improvement in his behaviors. And then after 9 months of treatment, the stretch marks were almost completely gone. All right, let's do another one with Layla. So Layla was a spunky, smart, athletic, sensitive, creative kid. She had no problems, but mom had babesia when she was pregnant. There was a family history of a lot of autoimmune disease, plus some psychiatric diseases. And her sister had had previous Borrelia-induced basal ganglia encephalitis. So the parents had already been through this with one child. This little girl liked things in order, but at this time she had a marked increase in OCD. That was a few years prior, but again, that came with this incident. So she had had something a few years ago that had then gone away. But in January of last year, she was exposed to COVID. She had transient diarrhea and lost taste and smell, but otherwise an uncomplicated course. But a few weeks later, everything changed. And she had constant looping, intrusive thoughts. She was begging for help. She just wanted to die. And she called it her bubble butt. She had jerking movements of her pelvis, and she found black specks everywhere and was afraid to eat, afraid of everything. And her handwriting went from this to this overnight. She was seen at Boston Children's, premier institution. They said it was all psychological, and she was put on sertraline, which is the brand name Zoloft, and Risperdal, and told that was all she needed. But due to her sister's history of previously having Borrelia, the family decided to pursue other avenues. So prior to coming to see us, she had had a mild elevation of mycoplasma, so maybe she had been exposed to that. She had a mild elevation of one of the strep titers, but that had been present before, so it wasn't that. She had past history of Borrelia and had a very high COVID antibody. She also had several immune markers that were positive. And as I mentioned before, when they have low CD8 or CD57, we often see that with Lyme or Lyme co-infections. She had a very low vitamin D and vitamin A, and they had seen no change with the Risperdal and the Zoloft. She was put on doxycycline before they came to see us, and she had some improvement. She was also put on ibuprofen, and that definitely helped. So we know that with ibuprofen, that's an anti-inflammatory, and that decreased the flares that she was having. So we know that inflammation was involved. She was also put on Celebrex as another anti-inflammatory, vitamin D and vitamin C. And then they came to see us. We wanted her on more anti-inflammatories. We wanted her on another form of that turmeric called Avea, very similar. We also put her on lithium orotate. There's wonderful research by Dr. Greenblatt that when they have this explosive, almost bipolar or manic behavior, that lithium orotate in very small doses crosses the blood-brain barrier well and can be very helpful in treating the symptoms. And then we started her on a rotation of herbs. We did not want to put her on further antibiotics, but we wanted to treat underlying viruses as well as any bacteria. So we chose olive leaf extract, oil of oregano, and silver, and we rotate those. We'll do 1 to 2 weeks of one, then the next, and then back to the first, and continue that for at least 3 months. Because of COVID and the virally induced nature of this, we also put her on what we call our acute viral protocol, which is lysine at 500 milligrams, vitamin A at least 10,000 IUs per day, but often higher than that, especially in this child with a very low vitamin A level. I will do much higher doses transiently and then go down. Vitamin D, and zinc. If they're already on any of these, we double the dose when they are exposed to a virus. Just with this, they saw vast improvements in the OCD, the intrusive thoughts, the anxiety. She was back in school and doing really well. They stopped the doxycycline. We did it for 3 months, 2 months symptom-free, and continued the herbal prophylaxis. She was able to wean the Zoloft, the Celebrex. She had already been off the Risperdal. So further follow-up, she'd been doing very well, then was exposed to another virus and began to have some more perseverations, bedwetting. And we put her on something called Aqualorin, which is monolaurin together with a biofilm buster. That is really a good anti-Lyme, antifungal, and particularly antiviral. And that, iced it. That really helped. Her cognitive abilities were back. Her emotional balancing was back. She was less picky with food, had a significant improvement overall. She does have some flares with infections. She does great with that curcumin exercise, and she's learned to do some meditation. Kids can do it. They can use mantras, even if it's let it go from, the movie Frozen. They can do it. One more case, and then we'll go to question and answers. This was a study we just published about 6 weeks ago, looking at cerebral or brain folate deficiency in kids with PANS and PANDAS. So the background to this is that, I used to take care of, as I said to you, children with autism, and they were found to have defects in folation and methylation. So Dr. Quadros at SUNY Downstate wanted to look at, is there a blood test that we can do to look at folate levels in the brain? Because at that point in time, we could only do it through a spinal tap, through a lumbar puncture. So we were part of the original studies with Dr. Quadros. And we found that that blood test that he developed was very accurate, that together with improvement with treating either with folinic acid or 5-methyl tetrahydrofolate and a high folate receptor antibody, that was diagnostic of cerebral folate deficiency and warranted treatment. So we started using that test in children with autism, then in our children that presented with autism and PANS or PANDAS. And then we were finding that more than 60% of our patients with PANS and PANDAS also had folate receptor alpha antibodies. So we decided to study it. So the folate receptor alpha antibodies were found, as I said, to be a proxy for this cerebral folate deficiency. It was found in 71% of children with autism in studies by Dr. Fry and Dr. Rossignol. And that treatment in those children helped communication as well as repetitive behaviors, helped them to be more calm, more better processing, less brain fog. And they were using leucovorin or reduced folate 5-methyl tetrahydrofolate. So we decided to study it, and it was a small sample size. It was retrospective in nature. It wasn't double-blinded, but we did find, as we see here, that 63.4% of the children just with PANS PANDAS had either positive blocking or binding antibodies. And so this is what we see. It's not the same as the MTHFR defect, but that genetic defect decreases your ability to take folate from food, like green leafy vegetables, and make it into methylfolate, which is what the brain needs. But in cerebral folate deficiency, there are also antibodies at the blood-brain barrier that doesn't allow the methylfolate to enter the brain. If somebody has the blocking or binding antibodies, these are antibodies to the folate 1 receptor. And that individual has to use the back door, sort of go in through the reduced folate carrier that lets leucovorin pass through, but not methylfolate. So the other thing we have found is that often when they have either not a good response to methylfolate or have not improvement with it, that switching to a good form of folinic acid or prescription leucovorin can be even more helpful. If you're not seeing any improvement and they have these defects, sometimes doing genetic testing, not just MTHFR, but other genomic testing, can be helpful in identifying what the child is going through. So this was a child I saw with autism, aggression, and severe speech disfluency. There was a lot going on. But at birth, she had a tongue tie and a sacral dimple. Those midline defects are much more consistent with an MTHFR defect. She always had slow progress with speech. But then she had a strep throat that was treated with amoxicillin, and her OCD and aggression exploded. It's an episodic hoarse, and decrease in her speech fluency. So she had been put on azithromycin when she came to our office after a second strep throat. There was some improvement, but not a lot. She still had the choreiform movements on exam and the keratosis, which is that chicken skin on the back of your arms or the sides of your cheeks that are indicative of essential fatty acid deficiency. So what testing did we do? We certainly did strep titers, but we did all the immune titers, the mycoplasma, the antioxidant mineral levels, the urine organic acid. And because of the midline defects and the speech problems, we did the MTHFR and the FRAT. And the treatment I started her on was leucovorin at 5 milligrams, a probiotic, because she had just been on antibiotics, ashwagandha, which is an adaptogen that we call the herbal Valium to help calm her symptoms, essential fatty acids for inflammation and because of that keratosis, and an antimicrobial rotation to further treat the strep, like the oil of oregano, olive leaf, and silver, and ibuprofen as needed. So these were her test results. The MTHFR was definitely positive. This is a compound heterozygous. She has one variant of C677 and one variant of A1298. She also had a positive FRAT. That is definitely a positive binding antibody. And this is one of the studies of folinic acid in children with autism and language impairment. So the mom came back, she had only added leucovorin. She didn't believe in any of those supplements. She only wanted the medication. So we had a very clean trial in this kid, and she had improvement in anxiety and like emotional ability just with 5 milligrams. So then we increased by 5 milligrams each week till we got to 25 milligrams twice a day. And then she was calmer, able to attend class. Her teachers noticed a big change, and her speech improved drastically just with leucovorin. So does a positive PRAF prove that a child has CFD? No, you need it together with improvement with folinic acid. Does having an MTHFR defect mean a child has CFD? No. You can have both, or you can have one or the other. Can just adding a multivitamin with folinic treat it? No, you need much higher dosages. Dairy consumption also blocks these antibodies. So a child that has these FRAT antibodies should be 100% dairy-free. And brand is important. I do have a methylfolate brand on my website. If you can get prescriptive leucovorin, that's great. Seeking Health has a good folinic acid that you can also try. So it's about putting it all together. It's a clinical diagnosis that may be confirmed by lab tests, but may not. It's the history and the physical exam confirmed by some testing. And these are the tests that should be done. I just repeat the same things over and over again. Sometimes good neuropsych testing, if the person is able to know the difference between a PANS PANDAS kid and another kid, neuropsych testing can help differentiate that. Additional testing depending on the presentation. If I'm really worried about meningitis or a tumor or seizures, I may do that. I do an EKG, especially if I'm going to put them on a medication like azithromycin, where I'm worried about their rhythm, or a sleep study to make sure they don't have sleep apnea. But most importantly, I use our treatment therapeutically, but also diagnostically. And that's the three-pronged approach of antimicrobials, immune modulatory agents, and symptom support. Diet is very important. The more anti-inflammatory diet, the better. More proteins, more good oils, more vegetables, and less carbohydrates. All of these are faces of PANS and PANDAS. The child with a restrictive eating disorder, the child that's not sleeping at night and sleeps during the day, the child with separation anxiety, with ADD, with rage, with OCD, with handwriting deterioration. And the child can have one of these or all of them, and it be PANS or PANDAS. So it's a clinical diagnosis abrupt symptoms or more subacute with Lyme co-infections, and mold. It's a three-pronged approach and earlier diagnosis and treatment. And that's why I use a lot of nutraceuticals, because you can do that without an MD or naturopath that can prescribe. Earlier diagnosis and treatment equals better outcomes, but it is still a marathon. It's not a sprint. And we need to make sure we're not blaming any of the families or the child, certainly. So it's always one child, one step at a time. I do mentoring consults all over the world. So if you and a practitioner you work with want to mentor with me, you can email Shannon. I'll give you her email at the end. And I also have a membership. And there's a discount code that I give to everybody that's here, and I gave to Claire and Jillian before. That membership includes at least 40 now, and we've got 40 more coming, short videos on all of this, longer lectures. And every month I do a live and recorded Q&A, either with myself or other experts in the field, or a monthly teaching. There's a resource section with all this in there, and then also access to my line. It's not available to everybody. It's only available through membership and mentoring. But it's most important to go where there is no path and leave a trail. This is hard work, but it can be done, and our kids can get better. So there's Shannon's email, swu@drohara.com, my website, and also a couple of my social media. So I'll stop sharing my screen in 1 minute. We got plenty of time for questions and answers. Hopefully answers.
Mm-hmm. Thank you so much, Dr. O'Hara. That was absolutely fantastic and very inspiring as well for all of us. So I'll start on some of the questions. I was so pleased at the end that you did mention including the azot, that's the anti-streptolizin, and the DNase B in your testing, because that is used here in England, even by the e-hospital, which specializes in pandas, as a preclinical test. We do always say it's not pathogenomic, as you say, it doesn't definitively prove, but if one doesn't have the money to go on and do a lot of further testing, there are quite a few families and clinicians who use that as a good hint as to whether
and 2 points. One, most of the tests I put in are all regular conventional lab tests, should cost no money. Yep. The strep titers may give you a clue, but if they're negative, that does not mean it's not pandas.
Absolutely. Right.
40% of kids will have immunodeficiency. So 40% will be totally normal and it still be pandas. So,
thank you. And one more question related to testing was whether there is a test for basal ganglia encephalitis.
No.
Well, that is indeed the Cunningham panel. I mean, that is,
yes, except that's $950.
I know, but it's a test for it. I mean,
yes,
it can be particularly, again, I must say this is the English experience, rather than having your child on sort of Prozac or Ritalin or whatever for the rest of their lives, being able to evidence, at least to yourself, and to then make progress with, look, this is pathophysiological, it's immune mediated and or infection mediated, and let's take that path instead. That
absolutely
can, it's weight in gold.
Absolutely. So and two things about that. Sorry. I absolutely agree and love the test. We were part of the original studies with that test, and it is a very accurate test. However, don't just base it on the CAM kinase, because if it's not strep, if it's mycoplasma or Lyme or mold, that will be negative, but your other antibodies that it tests may be positive. But again, 40% of kids, and even more than that, if they're not in a flare, will have a totally normal test, and it still could be PANS or PANDAS. So it is very helpful if it's positive, but if it's negative, it doesn't necessarily mean there's not basal ganglia encephalitis.
Absolutely. Just to finish answering that question, AONM, the academy here, does offer that. We are the representatives for that test here in the UK. So we can liaise that. Most definitely just contact us. And Professor Shimazaki, the CEO of that lab, is actually giving a talk on CAM kinase in neurodevelopmental disorders. So following on from exactly what you've just explained, and on the autoimmune brain panel, which is the new name that they're giving it rather than the Cunningham panel. So
Great.
that's on the 8th of May, and I'll talk more about that just briefly at the end. So
Great.
another question which came right at the beginning was whether parasites can contribute to PANS PANDAS.
They can. And there isn't a good test for parasites because, like Babesia and Bartonella, they often go deep, and so you can't see them. Certainly, if you see parasites in the stool, then it's positive. You can send that for culture. But I particularly ask about changes around the moon cycles. So if a child has a worsening of their behaviors or their tics or their anxiety around the full moon or the new moon, then I'm thinking about parasites, and I will treat as if and see if they get better. Treatment for parasites is like that Artemisia I mentioned, Mimosa pudica, black walnut, and wormwood, as well as some medications.
Brilliant, thank you. What would you suggest for persisting life-limiting OCD? I know at one point you separated that out from PANS PANDAS, but this attendee is just wondering, I mean, obviously this overlaps with your second case. So you mentioned quite a lot with that lovely little girl, but is there anything that you can mention just specifically, or a direction she should take?
The best nutraceutical for OCD is N-acetylcysteine or NAC. It is available in pill form, and there are some effervescent NAC from certain companies. NAC is it helps to increase glutathione, so it helps detoxification, but it also helps gliotoxins from mold. And finally, there are 17 studies that show that it helps to reduce OCD, like compulsive gambling, trichotillomania, nail picking, intrusive thoughts, etc. So that's the one we've had the most success with. I also find success with magnesium threonate. I also find success with some forms of CBD. I find success with lithium orotate. And sometime, as I mentioned, the ashwagandha, like the herbal Valium, can be helpful. But all of those are things that can be helpful.
Thank you so much. Could you just briefly explain what trichotillomania is?
Hair pulling, and they can pull out their eyelashes eyebrows. Yeah, I have that in a few kids.
And then Paul asks, what type of dietary advice did you give to the children to follow? I know you've covered that to a certain extent. And was it common to see histamine issues?
Absolutely. So especially with mold-related diseases, mast cell activation is very common. But with any of these inflammatory conditions, you can definitely see mast cell overactivation, mast cell-mediated diseases, and antihistamines are helpful. With mast cell-mediated, I use a little bit of a low histamine diet. I try to decrease aged foods, fermented foods, starches, carbohydrates, sweets, and no leftovers. So if you're one that eats leftovers, freeze them and then thaw them. Nothing left over. And increasing fiber and spices and garlic can be very helpful. In general, I'm always recommending as much as possible an anti-inflammatory diet, one that's high in protein, high in good oils, high in vegetables as much as possible, with some fruits, and low in carbohydrates. Now, if a child comes in already a picky eater with the beginnings of a restrictive eating disorder, I will go cautiously. But if they have that frat, they have to be 100% dairy-free or it won't work. So that's not just fluid milk, it's any animal milk, including sheep and goat and all of camel, and any yogurt, etc. So that is one I will do if they have that defect. Ideally, we should all be on a modified paleo diet or a Mediterranean diet or a modified carnivore diet, whatever term you want to give to it. But we also have to be cognizant that a lot of these kids have dietary restrictions that we don't want to emphasize early in their treatment.
Thank you. Yes, your detail on the cerebral folate deficiency was absolutely stunning. Thank you. And there are several questions related to that. With FRAA, is the treatment always higher doses of folate, or can the antibodies be addressed? And I'll just read the second part of the question. Is it lifelong, or does it resolve as there is less autoimmunity over time with treatment?
Great question. And, you know, when we were doing it in the children with autism, we were thinking it might be lifelong. But in these neurotypical children with PANS and PANDAS, we now think that even in the children with autism, and definitely in PANS PANDAS, that it is secondary. It is part of the autoimmune process, that in addition to those antibodies that are attacking the basal ganglia, like strep antibodies or mycoplasma antibodies or Bartonella antibodies, it's those antibodies, those protein that are attacking the brain. They're also causing that block at the blood-brain barrier. So yes, it can get better in treating the underlying trigger. But in the meantime, you also have to try to remove that block. That's eliminating actually dairy and providing an end round to bypass that block with folinic acid, or we have done it successfully with methyl tetrahydrofolate. It's just not as a direct a route.
Yeah, thank you. I'm sure you've partially answered this question, which is, do you advise against using synthetic folic acid due to the problems it causes with the DHFR enzyme in the folate cycle?
Yes, I do advise against it.
Yeah, and that unmetabolized folic acid then binds to the folate transport protein.
Yeah, I do not use folic acid. And I do recommend not eating folate enhanced foods. You'll see like cereals and things like that have, you know, folic acid, you know, all of that. You really don't want to push those. You really want to use folinic acid, which is a metabolite, or methyl tetrahydrofolate.
Thank you. I'll ask one question from the chat now, which is what your approach is if a child is sensitive to everything. I mean, do you find that using, for example, transdermal will help, or using more off-the-body types of therapy?
Yeah, and that's what I was going to say. You know, so first of all, somebody that's sensitive to everything usually has mast cell activation. And the one thing that a lot of those kids can tolerate is that turmeric. And I may start with that just in drops to see if they tolerate it. But other than that, I use the Epsom salts baths, the magnesium chloride baths, topical magnesium, topical glutathione, topical low-dose naltrexone, which is another wonderful anti-inflammatory I didn't mention earlier. So I will use that. I'm also a big believer in any type of physical manipulative therapy, craniosacral, chiropractic, lymphatic drainage massage, any of that. And certainly, as I mentioned earlier, CBT, DBT, you know, therapy in that way. Also, keep in mind that you can do a lot with diet, really just in decreasing the inflammatory foods. You know, your child is not the one going to the grocery store. You are. I told my family at the beginning of COVID, the store's out of everything. We're only eating these foods. So everybody in the house had to be gluten-free, dairy-free like me, and they had to eat a lot of protein, a lot of vegetables, and a lot of oils, or they starved. You know, I'm not saying to be too dogmatic in some of these kids, but you can choose not to get the foods that are inflammatory, and that will help also.
Thank you. And this is just a slightly different angle on that. What would you say to a parent who claims they have tried everything before and reject any suggestion like some of the antimicrobials, anti-inflammatories, etc.?
So the child is rejecting them, or they haven't tolerated them? Sorry, let me look at that question.
I'm assuming that the child isn't tolerating them, but maybe Suzanne will put in a little bit more detail.
Yeah. So I think a couple of things. Dr. Baker's right-hand person, when I first met him, was Maureen McDonald. And Maureen always said, you can't go through a window, you've got to go through the door. What I do first is re-ask about everything they did. Sometimes they use the wrong brand. Brand matters. If you're using a Now or a Gero brand, we found big differences between that and brands that we use. And I have all the best brands on my membership, if anybody joins, that gives you all the best of everything. They may have been doing the wrong dosage. They may not, what they saw as a negative may have been a Herxheimer or a die-off reaction, or it may have been because they had overactive mast cells and they didn't treat that first. Or there may be mold in the background or a tick-borne disease in the background that's never been looked at. So again, that history and physical exam helps to tell me, what might be the biggest triggers for that child and what we might try. And again, starting topically may be the way to go and inch our way in.
That's extremely helpful. Thank you. And this again overlaps with the previous two, but a little different. What are the best quick fix suggestions for behavioral flares when parents are struggling to make all the needed lifestyle, dietary changes, or to keep going with their protocols?
So first of all, there are no quick fixes. I got to say that as a mom that this started at age 9 and my son's now 25, he even had a flare when he got COVID a few years ago. But, and he's deathly allergic, had an anaphylactic reaction to ibuprofen. So I can't even use that. But ibuprofen is the first thing I use with a flare as a quick fix, 10 milligrams per kilogram. If they can't tolerate or are allergic to ibuprofen or that doesn't work, my second quick fix is turmeric. And then the last thing I wanted to mention is all of the things that we talk about to support our autonomic nervous system, our automatic nervous system, all the things that we should do automatically that our kids with PANS and PANDAS can't do. And we've talked about diet, but it's also getting outside, getting exercise, getting in the dirt, drinking plenty of fluids as much as possible, and also Wim Hof's cold hot. So a child that's like that may actually do well jumping in a cold shower or a cold plunge. It can reset things if they're willing to do it. And often what the kids are willing to do is take a hot shower and then end it for 30 seconds with a cold shower. And just that can reset that fight, flight, or freeze reaction.
That's super. Thank you very much. Gayer asks, with EDS, where patients have an increased tendency for autoimmunity, do you see that as pathognomonic for PANS PANDAS as well? Do you recognize that in the diagnostic road?
So there are a lot of children that have Ehlers-Danlos as a soft diagnosis because they have low tone and joint laxity and some amount of joint symptoms. I find most of those kids have some other trigger in the background and are indeed PANS or PANDAS. And often the trigger in that case is a tick-borne disease or mold. And they also have mitochondrial dysfunction, an inability of the mitochondria to react as they should. If they have real Ehlers-Danlos, those kids, so the soft sign ones definitely overlap greatly with PANS PANDAS. Real EDS is not a susceptibility to PANS PANDAS, but it can be an overlapping Venn diagram.
Thank you. One question here. This is a bit more personal, I suppose, say if it goes into too much detail. My son has Lyme and many co-infections. We suspect PANS and a severe seizure disorder. We're nervous about starting treatment in case of the worsening of seizures. Do you have any advice? Especially nervous of starting antiparasitics in case there are parasites in the brain causing a catastrophic seizure.
I think there is a lot of talk these days about parasites. And I think it is, as with everything we go through, there's a pendulum. And I think we've swung a little bit too far in thinking everything is bad. Every parasite is bad. There are a lot of parasites in our bodies that are helpful and healthy. So I don't want to overcall a parasitic and just put a child on an anti-parasitic. If a child has worsening of seizures or behaviors during the moon cycles, then starting with a very low dose may actually be helpful. But with any intervention with a child with seizures, it should be not as a, like, oh, this has helped other kids, or this is what everybody's doing, but very specific for that child and starting at a very low dose. As I said, when I start to treat, I start with 1 drop or sprinkles and build up slowly. If you do it in that way, you are much less likely to get die-off or worsening, even as with regard to seizures. It can happen, but it's much, much less likely.
Thank you very much. Afifa asks whether you have any experience with myrrh, and also when you say good oils, what you mean. So that's 2
Absolutely.
questions, really.
Yep. And I wanted to answer one other that was higher up because I see the Q&A. Myrrh I have used as a biofilm buster, but I do think aqualorin is an even better biofilm buster than almost anything else. So although, as I said, it has anti-Lyme, anti-yeast, and antiviral properties, it's also a great biofilm buster, and that's why it works so well. But myrrh can be very good, and I love essential oils like that. Good oils, though, what I mean is in the diet: olive oil, avocado oil, coconut oil, macadamia nut oil, something besides your really light oils like safflower, sunflower, vegetable oils in general.
Thank you. Relating to aqualorin that you've just mentioned, Scott says he has seen it lead to major flares in adults. And he
Absolutely
wonders if that's because it's a stronger biofilm breaker than it is antiviral. What are your thoughts on that?
Absolutely. Yeah. That's what I was referring to Scott's. And absolutely, I see that. And that's why I start very low. In children, I start with 1/16 of a teaspoon. And sometimes even with that, they flare. And then I'll add something like a cleansing support or a detox support, something along those lines, and try again later. Or I'll add more antihistamines or other biofilm busters and then start again. But usually if I start at 1/16, I don't see that bad herx. And then I can slowly over a month get up to 1/4 of a teaspoon, which is the largest dose I use in children.
Thank you. That's extremely helpful. Tess asks, do you rate intramuscular penicillin for PANS or for Lyme and co-infections, or both, of course?
Yes, I have one young man who's coming every week for me to do that. And for those of you who don't know about bicillin, it's a long-acting form of penicillin that is a very thick white liquid and is very painful, even when you add lidocaine. And so a lot of children do not tolerate it. I will often do 1 dose at the beginning, especially if a child has a lot of gut problems and gut dysbiosis, and I don't want to put anything in their intestines to start with until I get their gut better. I will do a dose of penicillin to see if they improve, because it is a treatment of choice for Borrelia as well as strep. But doing it on an ongoing basis can be very painful. So there are very few kids I do it longer than, a dose or 2. But I do have a young man every now and then. I've got somebody that tolerates it and we do it. So.
Oh, yes, I know it is used here in the UK as well. They're more for Lyme and co-infections rather than for...
mainly Borrelia.
Yeah. Sheila asks, how do you distinguish true food sensitivities from food aversions or food avoidance?
So, when you have a sensitivity, the child will crave that food usually, not avert it or avoid it. That's usually what's true with food sensitivity. So if they're craving a food, I take it out for 2 weeks, 100%, and then I pig out on it. If the behaviors get better when I take it out, or they get worse when I pig out on it, and pig out is 3 servings a day for a couple of days, then I know they're sensitive to that food. You can measure it. Some conventional labs will do that, not entirely accurate, in some specialty labs, but it's very different than the food aversions, which is true in ARFID and certainly in a lot of our kids with restrictive eating disorders.
Thank you. You did mention a live vaccine at the beginning of the talk related, I think, to your own child. Don't answer this if you feel it could be problematic, but one question has come in. Can vaccinations act as a trigger for PANS?
So as a mom, I will talk to you now. I'm not talking to you as a doctor. I'm talking to you as a mom. But what vaccines are meant to do is induce an immune reaction. That's what they're supposed to do. We want to develop immunity to tetanus or measles or varicella or whatever we're giving the vaccine for. Most of our children can tolerate that. But if our children have an autoimmune disease where their immune system reacts against self, yes, it can be a trigger. And particularly when you're giving a live viral vaccines, we can see that. Now, we are not anti-vaccine. We cannot be. I will lose my license, so please don't tell anybody that I am. But we do a vaccine protocol. And one of my colleagues, Dr. Wells, wrote her thesis on giving vaccines safely. And it's a group of antioxidants the week before, the day of, and the week after that can help children tolerate them better if you need to do that. And my colleague, Vicki Kobliner, is able to take patients from all over the world and can give you the details of that type of protocol if you are interested.
That's amazing. Thank you. Britt asks, can a child have mild OCD and not PANS PANDAS? Or does OCD always point to some kind of brain inflammation? And she does add, it's only intrusive thoughts and wanting reassurance, not physical compulsions.
Yeah. I think, and I think you saw this when you were just at the ILATS conference in Germany, all neuropsychiatric illness is brain inflammation, period. End of story. 75% of neuropsychiatric symptoms in a Denmark study of over 7 million people showed that they had tick-borne disease in the background when they had neuropsychiatric symptoms. So I would always look for it. Can you have OCD without PANS, PANDAS, Lyme, mold? Yes, absolutely. But I am going to rule everything else out before I say it's not one of those other things.
Understand. And yes, you're absolutely right that this was definitely, the findings of Professor Bob Bransfield's in Germany and Dr. Greenfield and others, who will incidentally be speaking to us very soon on our AONM webinars as well. So another question from Afifa was, she thanks you for discussing myrrh and the oils. She wonders about animal fats.
Yeah, I mean, it depends. And there's another question a little bit lower about sensitivity to an aversion to meat. So Absolutely. It depends on the individual child. So there's something called alpha-gal that is induced by some Lyme infections. And if your child has a reaction, a negative reaction to meats, or an aversion to them, you should check for alpha-gal. And if the alpha-gal is positive, you should check or treat for vector-borne diseases like Borrelia, Babesia, and Bartonella. But in other children that do not have that, animal fats are very good. I like lard. I like using ghee. I like using a lot of animal fats because the oils are very important for the myelination. phospholipids in general are very important for not just communication, but thought processes, et cetera. And none of us in this country, we have a much sadder diet, SAD stands for Standard American Diet, than you do in England, and certainly in the rest of Europe. But what we're missing is good oils. So we need those fats in any way we can get them.
Understand. Thank you. That's triggered the question, what percentage of your PANS PANDAS patients do actually have tick-borne diseases, would you say?
Well, we have 42% with Bartonella. We now have about 40% with Babesia, and a much lower percentage with Borrelia. But remember, I have a very skewed view of the world. Everybody that comes to see me has neuropsychiatric symptoms. So these are of the children with neuropsychiatric symptoms. 42% have Bartonella and a little bit more than 40% have Babesia.
Yes, and another question was, up to what age do you take patients?
Well, I cannot take any patients as like I'm your consultant and I treat you outside of Connecticut, New York, and New Jersey. But I can do mentoring consults for anybody at any age, anywhere in the world. And that you set up through my website, and that'll explain everything there.
Right, but the age that you take when you do see patients from your catchment area is up to 16, I believe?
Up to 16, right.
And not older.
So if anybody's on here from Connecticut, New York, or New Jersey, yes, up to 16, you can become a patient of mine. My waiting list is now into 2025.
Oh,
yeah.
my
But my
goodness.
mentoring consults I can do as early as June, I believe.
Mhm.
June's filling up though. But
everybody is saying what great information this is. Fantastic. Thank you.
Yeah.
One question that's just come in, and it's interesting, but of course, a little bit sort of just one slice of the problem. Is there anything that would help repair a broken myelin sheath?
Phospholipids.
Okay.
And there are a lot out there. I mean, essential fatty acids are the first step. And the biggest mistake we make is not giving enough of them. If a child tolerates fish oil without easy bruisability or nosebleeds, then keep going up. My colleague, Dr. Joe Maroon, wrote a book called Fish Oil, and he gives 10 to 18 grams of fish oil a day. That's a lot. I love to get to 6 grams if I can. Then you've got things like phosphatidylcholine, phosphatidylserine, citicoline. Then you have other things like we now have peptides. There's a company called Prodrome that provides phospholipids like Prodrome Glia, Prodrome Nora. These are all available all over the world, but that is something you can do. Absolutely.
Thank you. You've just mentioned citicoline, and I know we had a question about that, but I can't find it right now. I'll find it maybe in a few minutes, but I know we don't have much time. We're getting close to your cutoff. But just a couple of questions that came in from last time that we hadn't answered. How does striae differ from stretch marks? If you could just repeat that. I know you talked about them turning a different color when you put pressure on them.
Striae is just the doctor name for stretch marks. They're the same thing, except what's different between Bartonella striae or stretch marks and those from growth or stress or weight changes is that the Bartonella ones blanch. When you press on them, the color changes. Also, the Bartonella ones are either horizontal or vertical. They do not follow dermal lines in a slanted pattern. The ones that are from growth or weight changes or stress follow those dermal lines in a slanted pattern.
Thank you. And a doctor from last time, who may be on today as well, asked, in my practice, a high proportion of children have cryptopyruria, KPU. I know there's a slight difference between KPU and HPU, but I think you said last time that you find the same.
Absolutely. And we find so much of it that we stop testing. We just assume. And it's expensive. So we just checked zinc levels or zinc and copper levels. And the main treatment for that issue is increasing zinc and B6. And we use a lot of B6 and magnesium anyway.
And
So
sometimes manganese as well, right?
absolutely,
Yeah,
absolutely. But the big thing is, whenever I do a test, I always say, what am I going to do differently with the results of this test? And I didn't mean it all to poo-poo Moleculera and Craig's study, because it's an amazing test. But for me, if it's not going to change my management, that's why I don't do it as much anymore, because I assume they have the inflammation. But if I need to convince somebody, or it helps to get the appropriate treatment, it is the best test to do. I
mm,
also saw one question, this may be the last one, but I just wanted to mention adults can get this disease. That
absolutely.
blood-brain barrier now that is breaking down, that usually closes between the ages of 21 and 25. But now that we live in a more and more toxic world, the blood-brain barrier is becoming more and more leaky, just like our leaky guts. And
Absolutely.
so, especially if it's not treated fully or at all as a child, or if they're just exposed to a lot of toxins, or it's a tick-borne disease or mold, especially, absolutely this can happen in adults. So forget about the P in PANS and PANDAS.
Thank you very, very much. Yes, you're absolutely right that we should probably close up now. I had just seen one question that I did feel it would be nice to just touch on, which is Tess asked, is the CAM kinase always associated with strep, or can it relate to other infections? What I'd like to suggest, Tess, is that you join us on the 8th of May when the CEO of Moleculera, Professor Craig Shimazaki, will be talking about exactly that point. So let's not go into the details of that, because it's quite complex, isn't it? And what
Absolutely.
markers mean. But we will be addressing specifically that for 1 hour, beginning at 7 on the 8th of May. So, Dr. Hara, thank you so, so much. That was just incredible. And we can't get enough of you. And everybody's writing what a real gift you are to this world. Luckily, there is quite a lot of your work available on YouTube and other sources. And you've mentioned your mentoring. Somebody did ask what the code is. And if you don't have that in mind right now, then we'll probably send it out to everybody, if that's okay.
Yes.
Yeah.
Yes.
Right after.
Absolutely. I'll have Shannon send that.
Yes. And what I would love to see happen is for a group of therapists to come together to do mentoring with you.
It would be
And maybe we
great.
can maybe we can build a little group to
That
do
would
that.
be awesome.
We have done that with other doctors in the past, and it's just so incredibly valuable.
Yeah, and the mentoring can be with 10 people or 20 people, and the membership is available annually for anybody that joins, and you can share it, and there's so much recorded there. So not trying to sell anything, but just trying to get the
No,
word out
no,
and get
that's what
everybody on
we do
board.
need that here in the UK.
Absolutely.
Thank you so much again. Just to mention very briefly the upcoming webinars. There's one next week, in fact, on Tuesday, called Revolutionizing Lyme Disease Management, Predictive Modeling and Diagnostic Innovations Unveiled. And as you spoke about the percentage of Bartonella and Babesia patients who you have, and Borrelia, I can see that you do exactly that. You have a fantastic sort of statistic, data keeping algorithms in the background, which is what this will be about, is helping us to build those a bit more here in the UK. Professor Shimazaki, as mentioned, that's, by the way, with Professor Leona Gilbert and others, Kunal Garg as well, who you may know from our mycotoxin webinars. And she's just brought out a book called Borrelia Protocols. So she'll be talking a little bit about that too. And then Professor Shimazaki on the 8th of May, as mentioned, that's a Wednesday. And then again, Professor Gilbert, but this time with Dr. Schwarzbach and other authors of a chapter in her book about the Ellie spot. And they'll be talking about that, which I know you mentioned testing for Lyme and co-infections. And what's lovely is that we're able to use Armin labs very well here in Europe because we're so near. I know it's a lot harder sending in the samples from Europe for a T cell test, but the Ellie spot is something we do very much, prize here, being able to use in the UK. And so Dr. Armin Schwarzbach, who runs that lab, will be speaking about the adaptive immune response in Lyme borreliosis. That's on the 18th of June. So,
And I'm so sorry, Jillian, I do have to leave now.
yes,
So I
absolutely. No,
so appreciate it.
very much. Thank you. And
Thank you.
see you again. And everybody who's been here with us, thank you for spending the time with us. Bye bye.